Excellent.
Good morning, my friends, and thank you so much for joining us for our poster symposium for Return to Care. We are so excited to have you all on the line and to share your progress with us as we work our way forward the end of 2021 and round the corner into 2022. And I'd like to just point out that we have so much support and energy going for us as we are, sharing today and welcoming a lot of our stakeholders from the state and the local level to hear our work. So I'd like to turn it over now to Sonia Hughes to offer some words of welcome. And also, I don't know, we hear that the judge will likely be joining us in about like 20 minutes or so, 30 minutes. Is that right?
Yeah, so good morning, everybody. And thank you for joining us this Monday morning. And so we're definitely happy to have you here and to showcase all the efforts and the progress you've made in partnering with our CQM program over these last couple of years. We know that the CQM program is so much more than a HRSA grant requirement. It's about creating a culture of quality and quality improvement to improve the healthcare of our consumers and also increasing other patient satisfaction. So ultimately, we can optimize health outcomes. And so through our collaboration, we can only strive to improve our CQM programs and address disparities in our community. And so, again, we're excited to see everybody's posters and definitely look forward to the continued partnership. I would also like to add that our HRSA project officer, Kristen Athey, was able to join us today. So we're excited about that and also appreciate her support. So thank you to our CQM, Dr. Salinas for leading the program, Angie and Regina as well, and then for the support of Michael and Jamie. We couldn't do all the work without you. And I don't want to forget our state partners as well, with Julie and Teresa, and for the support of our leadership in Dallas County. So Dr. Wong, our director, Ganesh, who supports our program, as well as our deputy director, and then our county judge. I couldn't do it without his support.
Thank you so much for those words of welcome. And now I'd like to see if Julie wants to provide any words of welcome and encouragement from the state's perspective. Julie?
Thank you, Michael, and thank you, Sonia. Yes, I am so excited to see the great work that y'all have been accomplishing the last year. I've been hearing about, tidbits here and there. Super excited. You make Texas proud, making us look good and helping our clients achieve their best health outcomes. So super excited, can't wait.
Awesome. And I don't know, Oscar, if there's any additional words you'd like to say before we kick off.
Well, I get all of you kind of tired of saying, hearing that. Thank you from my end. I want to thank you again, because all of this work is the collaboration from your hands, your work, and your participation and coordination in aligning to end of the HIV epidemic, which is the main goal of the whole CQM portion, aligned with those programs who are gonna be like successful by 2030, hopefully. And without your help, wouldn't happen. And thank you very much for being here to take this Monday. The priorities included the CQM as a priority as well.
All right, and as we roll forward, thank you, Dr. Salinas, and thank you everyone for your words of welcome. Just a couple of other acknowledgements. We have the Achieving Together, folks that are kind of watching what we're doing, and we had the Ending the HIV Epidemic folks from Dallas County also on the line today, celebrating with us and listening for opportunities. Just some quick notes on our Zoom environment. Some of you, I think, are new. You can press escape to exit the full screen. If you hover over where my face is talking in the corner, you'll see that there's a widget that you can change the camera views. If you want to see more people or less people, you can take care of that. We encourage that folks leave themselves on mute so that we don't have any unwanted distractions. If we notice that there's some noise coming from your line, we're going to go ahead and mute you. But please definitely unmute to chime in when we have conversations. Of course, you can also use the chat room to interact with your colleagues. You'll see that there's, just a quick thing. I know that many of you are already saying hello in the chat room, but since we do have a broader audience, and I'm a foodie, I can't help it. I think a great icebreaker is your name, your organization, and maybe your favorite restaurant locally, so that we can get some conversation going and to think about food. We also highly encourage you to use your webcams. So when we take the slides down and have an open dialogue, it's just so helpful to be able to see each other and to react to each other and to play off each other in that way as well. And of course, you may have noticed that the meeting is being recorded like all of our meetings. This meeting will be saved in our YouTube channel and will be accessible to all within a day or two of our presentation. Oops, wrong button. Let's try this again. There we go. We looking at slide 4? All right. So learning objectives for today. Today is about summarizing the work that we are doing. So we want you to be able to summarize the work that we have so far on a system basis in an elevator speech. We want you to be able to talk intelligently and concisely about what it is that we've been up to as a region for the last year. We also think that by this point in time, you should be pretty strong in having an elevator speech describe your specific subrecipients, organization, QI project, and results to date. And I think you've accomplished that since you basically are presenting posters today. But for those of you who weren't involved in your organization's poster, it's great to listen in and to find that elevator speech that works for you in sharing your work with your colleagues and other stakeholders beyond your organization. Elevator speech again on how our subrecipient organizations' services play meaningfully into keeping area consumers consistently engaged in their care, which of course is the purpose of Return to Care. And you'll see that a lot of our posters and our activities actually speak to the importance of social determinants. So I think we're pretty solid on this too. And of course, our last learning objective, since we're renewing Return to Care, we want you to complete an action planning form that will focus your agency's next steps for your QI projects. Many of you have addressed things like this in your next steps, and so we're going to be listening for those themes, but we should definitely be using the action plan to plot forward what it is that we're going to be doing in 2022, and of course, to take advantage of the great support that we all have available for you to make sure that you are feeling comfortable and confident in the next steps your agency will take for 2022 in Return to Care. So the participant toolkit is basically a action planning form, our presentation slides, which of course is a digital poster compilation. Many of you have updated your posters. So we're going to send out another version of this following the presentation so that you all have the most up-to-date posters that are presented today. And you'll also get a regional cross-cutting report in the toolkit that will summarize our activities to date beyond the information that we'll have available in our slides. Okay, so I'm going to kick it over to Jamie to walk us through some quick housekeeping before we dive into the poster symposium in earnest. Jamie, take it away.
Awesome. Good morning. We can advance to the next slide. This is really an exciting morning because y'all, we did it. We have made it through a full year doing a regional QIP project. So while the work continues, I hope everyone takes a moment to soak in what we've all kind of collectively done. So where we are, you kind of see that timeline. We did our kickoff in April last year, and we find ourselves at the poster symposium today. We have had some hiccups. We always say kind of building the plane while flying it. So this first ever regional QIP, we're kind of at a midpoint for some folks. So the poster symposium today will sort of act to share what the highs, what the lows, the good, the bad, the unexpected that we have collectively experienced so far. But we do encourage you to still share the link from today and that sort of poster compilation with your QM teams and with other stakeholders. We can go to the next slide. So just in short, some of us are going to continue to work on implementing the same change ideas that we're standing up over the course of the year. And we are developing, we're very excited, we're developing sort of this extended capacity building series for Return to Care in this 2022 calendar year. And what we hope to do is bring in some outside speakers to address common threads that connect your different projects together. So stay tuned, y'all, that'll be awesome. And then in terms of potential pivots for 2022, So you'll hear from folks, some might be doing some shifts or changing their projects. So folks will go through that QIP lifecycle with a discovery process, a root cause analysis process. But no matter what, we expect a similar timeline. So you see this here, where discovery would happen by April of 2022. Folks could wrap up their root cause analysis by June of 2022, and then testing of change ideas that takes place between July through October. And then we're going to also repeat the same thing with a poster symposium next year as part of our regional World AIDS Day celebrations. So all of this continues to build, and we're just really excited as we think of what we've accomplished and also look forward to what lies ahead. So speaking of lies ahead, Michael kind of teased this out, right? Action plans. Hey, and I have been a subrecipient before, and these action plans are a big value add because it helps put on paper, sort of like Michael said, plot out, do folks want to adjust their aim? Are there some shifts there? How will you ensure successes are gained? So even if you don't have a strong sense just yet, whether you're affirming or switching, what you're doing, the action plan is going to be a great tool to use with your agency and use it in collaboration with your quality management committees so you can develop and sort of track those concrete steps that move you forward. I'll turn it back over to you, Michael.
All right. Thanks so much, Jamie. And, you know, now I think it's time to really dive in and to whip out my timer here. What's good for the goose is good for the gander, as they say. So I'll start my 4-minute timer now as we talk about the Dallas Returns to Care. And this is really a regional story of learning and excellence that we'd like to share with you. So our bird's eye overview is that we started our initiative thinking about our entire multi-county region, and we had 2 main clinical goals. The first goal was to decrease the no-show rate of scheduled outpatient ambulatory health visits at funded subrecipient organizations by 10 percentage points to basically have a system-wide outpatient ambulatory missed visit of 20%. Now, it's important to note that this information was developed by survey, our discovery. So I want you to know where our information came to set this aim. We had surveyed some of our big OAHS providers to develop that. And our other big clinical aim was to increase the rate of people living with HIV who access medical visits by 25 percentage points to a 70% regional retention rate by the end of 2021. We did have a logic model that pretty much drove the way that we had designed our project here. We had, a number of different activities that were designed to have specific outcomes. And so that is going to be present in our cross-cutting report. And I think an important lesson learned to share on this slide really is that, we had a large number of organizations reacting to us as we were sharing back. And it turns out that almost all of our activities have some sense of social determinants of health in their framework. And I think that that is so important to note. Obviously we had specific focuses for our, individual agencies and the services we provide, but we wound up focusing a lot on our social determinants of health across our organizations. So, where did this come from? We all know, we've talked about this a lot. We needed a regional project. It's been a finding from our federal partners, and it's 2020. As a person living with HIV myself, it's really important that we push ourselves. And so it's incredible that we were able to pull together this regional project and to have all of your support and all of your loving attention and activities as we worked our way forward. As I just mentioned, a survey is how we identified where we wanted to focus our return to care activities. And of course, retention, as we had noted at the outset, is a key focus of Fast Track Cities, Achieving Together, Ending the Epidemic, and so many other key initiatives that this really created a low bar and easy entry for all of our different providers. In 2021, we used mixed methods of pre-selecting an optional intervention for OAHS providers. But of course, we used our general CQII-based methodology as well, where, people were able to drive their own individual activities based on their data. So when we think about changes at the system level, the most important thing is when there was once no project, we now have a project that's tied to other initiatives and a function. And in this way, out of one activity, we have many, many applications. We see the Achieving Together framework on the right that really emphasizes so many of those key social determinants of health. And we were able to identify quite a few common threads across your projects. I don't really have time to go into the image on the left that's been in past presentations. You can get more detail if you watch the November recording. But basically, this plots out all of our many activities across our subrecipient agencies and how that affects the Achieving Together framework. In my last 5 seconds, some next steps here. We have the continuation of our project. We have action planning to facilitate that. And we are going to be implementing a regional satisfaction survey in 2022, implementing both E2 and Take Charge Texas in 2022, which will affect our ability to track, and some psychometric testing of our PROMs and PREMs in 2022. The last thing that I'd like to say is that we want to have greater community involvement and discussion this year. So that is that. And I think, Jamie, you're going to be our MC for our subrecipients, right?
Hey, yes, yes, yes. So we have a lineup coming. So yes, Michael will keep time. So this is our batting order, folks. And one of us can also drop it in the chat. But we're going to start off with PRISM. Then we'll do AHF and RCD. So I will turn it over to PRISM. Take it away, folks.
Good morning, everyone. I am Victoria Langston. I am the Director of Clinical Compliance at PRISM Health. First, I would like to thank everybody for their time because I know everybody's incredibly busy. So thank you. Next slide, please. So in the midst of COVID, as we quickly stopped in-person care, trying to find a way to continue to see patients, we implemented telehealth across the board. What we found is that it has been a great way of not only communicating with patients, but keeping them in care as well. We also learned that telehealth does help to overcome some barriers created by social determinants such as transportation, lack of childcare, and stigma. So our aim, our goal for this project is to decrease the no-show rate of our cis and transgender women patients by 5%. And as a result, we'll increase viral suppression in those groups by 2%. Our team is Dr. Deborah Morris-Harris. She is our CMO. Kathy Bryan is our Executive Vice President of Patient Services. Amy Barrier is our nurse practitioner. She is the one seeing most of the patients, and then also all of the clinical support teams. Next slide. So when we started to think about what our project was going to be, we were looking at specific patient populations, and what we discovered through our baseline data shows that women have a higher no-show rate than men. So the no-show rate for women is around 50%, while for men is around 25%. Our trans women also have a similar no-show rate. So we decided we would focus on these groups and we would choose patients from this group and provide them with the tablets. So next slide. So we also created a survey that we wanted these patients to complete so we could really understand what their barriers were. So our study hopes to demonstrate that telehealth will reduce the no-show rates by helping to overcome some of the barriers based on the survey questions. As a result, viral suppression should also increase. Our survey was provided to determine risk factors for those patients with a high no-show rate. The survey is a tool that was developed by CMS from previously validated questions in each of the domains. So what we found is unmet social needs such as homelessness, inconsistent access to food, domestic violence, and also transportation, childcare, like we talked about earlier, really impact a woman in particular's access to care. So when we present the tablets to the patients, we are also going to present the survey and we will collect that information at that point. So next slide, please. So we had intended to have our tablets out before the end of the year last year. We received them in mid-December. And unfortunately, first with the holidays and trying to get people scheduled, we were going to try and get them out in January. And then COVID decided to rear its ugly head again with the Omicron variant. So we delayed scheduling patients to come in. We are actively scheduling them now to come in February. They will get their surveys and their tablets. We will provide training on the tablet use. And once the patients have their tablets, they should be able to access their medical visits via the tablets. If the patients are not compliant with their medical visits via the tablets, the clinic support staff is going to work with the providers to reach out and try and understand what barriers that patient is having and what we can do to assist with those barriers. We will then also continue monthly reporting on those patients and their outcomes to the Dallas County CQM committee. We also, at PRISM, we have an affiliation with the South Central AETC, and we hope to be able to use the ECHO model to help us disseminate the results from our study. Thank you.
Awesome. Thank you, Victoria. I really love hearing how you looked at your data and you focused on that population. This is very interesting information. So awesome. Congrats. Thank you. Thank you.
Thank you.
Yeah, we do have AHF up next, but I believe our project officer joined the call. So I wanted to pause for just a moment and say hello or see if anyone wants to say a word of welcome.
Oh, hi, good morning, everyone. My name is Kristen Athey. I am the Part A project officer for the Dallas EMA. So thank you so much for inviting me this morning. I am very excited to hear just so far what I've heard about the great work that's been done and kind of the plans to continue all of these efforts, and getting people linked up and retained in care and achieving viral suppression. I mean, it's so important. Before I came here to HAD, I was actually a subrecipient for Part A funds. So I really want to thank you all for all of your hard work, especially with COVID and how you kind of pivoted to implement all these telehealth and all the great work you've been doing. I've been working with Dallas for about a year now, so I'm still relatively new, but I just want to thank you all, and I'm looking forward to the rest of the presentations.
Thanks, Kristen. Sandra, take it away.
And actually, can we let Judge Jenkins speak briefly as well? We're happy that he was able to join us today as well. So thank you so much for supporting our CQM program.
Well, I just want to jump on and say thanks to our subrecipients for their collaboration and expertise as we built our clinical quality management program from the ground up. I know you all have been working very diligently on quality improvement projects to increase retention in medical care, viral load suppression, patient satisfaction. Our community, our patients, our residents will greatly benefit from your hard work and commitment to the care. And for that, I sincerely thank all of you.
Wonderful. Thank you so much for joining us, Judge Jenkins. It's really an honor to have you here. And, it's really wonderful to have support at all levels, as we had mentioned, our local partners, our state partners, our federal partners. And, we couldn't do this work without your amazing support. So thank you so much for all you do. And now, Sandra, you ready?
Yes, I am. Thank you so much, Michael and Jamie. And I'm timing myself as well. Hi, so my name is Sandra Najuna. I work with AIDS Healthcare Foundation. I'm the Senior Project Manager in charge of quality management for RWHAP contracts. Next slide, please. Yes, so it's not just me from AIDS Healthcare Foundation, and a couple of us are on the call today. I am the quality lead, so to speak, but we also have Jonathan and Hosea and Johnny and Astrid and Shibu, who is our contracts director. And this slide shows what the particular positions are, but they've really been a great part of the team and part of the quality management team, which is a bigger team that has both staff from the health center and staff and senior leadership. Thank you so much for joining. And our aim is to decrease the rate of patients who haven't been seen at AIDS Healthcare Foundation or AIN for the last 13 plus months. And our aim was to increase by 5% from 59% to 64%. This also happened to coincide with a campaign that's going on in the company to bring, it's called the Back to Care campaign. And that really is aiming at that same, it has the same aim to reduce, to increase our retention for our patients. So both projects have been working hand in hand as we go on with Just Dallas and the nationwide campaign in AIDS Healthcare Foundation to improve our retention rates. Next slide, please. So what have we done? First of all, we have a great team, both from AIN and from IHF. And like I said, senior leadership has been very supportive. And we also had a great collaboration with we've had lots of emails and meetings back and forth. And one of the things that I feel like has been a success is the technical assistance from Dallas and from Michael and Jamie. We've been on several calls with them and they've really helped a lot. Some of the challenges we've had is that lots of our clients change address and do not update us. As a matter of fact, it's part of the reason why we did not have a special population, because at the beginning we had about 148 patients on that list and we could barely get in touch with about 10 of them. So it's hard to specify a population when you can only get in touch with about 10 people on the list. And then we always have a gap list, but some people on our gap lists have not been in care for 13 months yet. So they're kind of in the waiting area, 12 months. Then when they drop off to 13 months, we then get in touch for this particular project. And we've also had a challenge for consumers finding time to be trained and also understanding the terms of collaborating with Continued and AHF and AIN. That took us some time for us to figure that out. Let's go to the next slide, please. Next slide. Yes, so what was, so this slide shows the root cause that we used to determine what our project is going to be. And I'm not going to go into it because we don't have a lot of time right now, but what we mainly had was a meeting between, with the quality team, and then we accessed the patient's EMRs and looked at what some of the root causes are based on the conversations we've had with them in the past, since we could not quickly do a survey and have it back in time for the project to go on. And something else I'll mention that I might have skipped at the beginning is that we got our 10 tablets maybe in November, and we already have 2 tablets out. We have 5 patients that agreed to be part of the project, and 2 of the patients so far have their tablets. So we, next slide, please, which I think we'll talk about the next steps. I think I talked about this a bit. Oh yeah. 2 out of our 10 consumers already have projects, already have their tablets. Let's go to the next slide, because that's when I'm going to talk about the next steps. Apologies. Yes, so the next steps, we're going to continue with this project where we've already trained 3 staff. Jonathan, our practice manager, is trained, as well as 2 patient care specialists. So we're going to continue reaching out to patients, seeing how many patients we can get to give tablets so that they can access their medical, they can be able to get other medical services on there or reach out to us if they would like to. So I've run out of time. I'm going to stop right here, but thank you so much for listening.
Thank you, Sandra. Thank you. Thank you for sharing the successes and challenges. You know, it is one thing to ID folks and then get tablets and get training and get it off the ground, but you know, you've got it going. So thank you so much. We have RCD next.
Good morning. My name is Del Wilson. I'm the RWHAP Program Director for Resource Center. I'm also the Quality Director, but that just makes too long a title. So
You're muted.
Del, you muted yourself.
We lost you.
I swear I turned it off and I must have immediately hit it again. My name is Del Wilson. Did you hear that part? I'm the Quality Improvement Director and the Brian White, Program Director for Resource Center. Our quality project involves the Latinx population of our clinic, which is primarily males. But the aim of our project is to increase the percentage of Brian White funded Latinx patients retained in clinic care to 70% by the end of calendar year 2021. So that year is just wrapped up. We'll be keeping the same aim, I think, maybe adding another one. And our tablets, we have 2 tablets with patients. They've been out in the field for just a few months now. And so obviously we're going to want to look at that over a longer period of time. You see our QI project team included QM committee, our prevention director, practice manager, nurse practitioner, and medical assistants. And what we learned is our newly diagnosed limited English speaking, non-English speaking medical patients have significant barriers other than just language that make it difficult for them to enter and stay in outpatient medical care. So some of these same patients that we're looking at are often have a deficit in personal technology, either in the knowledge or just on how to use personal technology, or just the lack of having the technology because of the cost of cell phones, tablets, internet, et cetera, internet access, et cetera. And so some of these clients the patients we're talking about here are actually not facile with using personal technology, but with patients, they can be brought along pretty quickly. Next slide, please. So Resource Center is an LGBTQ plus affirming outpatient medical clinic. We opened one in July 2019 for self-insured and self-pay patients. The organization has recently affirmed that we are an LGBTQIA plus affirming organization as an advocacy agency that has many programs. We have a long history in prevention, HIV, STI prevention work. We have a long history in PrEP program. We have a long history with trans hormone program. But until July of 2019, we had never had an outpatient medical clinic. We received Ryan White outpatient ambulatory health service funding, and in July of 20, we're also were able to welcome in non-insured people living with HIV who are Ryan White eligible. Soon after we opened to this population, our clinic began receiving referrals from our prevention testing program that included a noticeable number of non-English speaking and limited English speaking, non-insured, newly diagnosed HIV positive individuals. And so that's what we had not necessarily expected that in advance, so that caught our attention, and is the reason we chose the subset. So some of the barriers, some of these individuals have very little history of regularly engaging in medical care. Most were working in low pay, relatively low paying job, and didn't feel like they could miss work, not only because of the reduction in income, but just out of fear of losing their jobs. Stigma was a big issue if they were perceived by other people to be HIV positive or MSM. So those were things we had to provide a lot of support around. It's not on the chart, but many of these individuals also didn't have their own personal transportation. They had to rely for work, medical visits, everything on public transportation and or friends and coworkers for transportation. Next slide. So we needed to, and we did add during the course of last year, we added a Spanish speaking provider and additional staff members who speak Spanish. I didn't say, but we're relatively small. In addition to being a new outpatient medical provider for Ryan White, we're a relatively small clinic, and we're growing. But with the short history of being in this area, we're also a small clinic. So we added the language line sort of across the agency, and we use Spanish-speaking staff members in other areas of the agency when we need that in the medical clinic. Right now, almost everyone who works in the medical clinic speaks Spanish. So it's very good. We assure people that their sexual orientation is the right one for them, and we are inclusive, and we support that. We embrace it. We've learned that.
I'm sorry to interrupt, but we have hit your time limit. I don't know if there's any real high points you'd like to note on this slide or the next slide. I'm so sorry to do that to you.
Yeah, it's okay. Let's go to let's go to the next one.
I think this is a great presentation, though, and you're talking about a really important issue for a really important key population that our state partners and our local partners have pointed out to us multiple times. So that's not to discredit you or this incredibly important topic you're talking about.
Well, what do you think about the emojis? No, later.
I love them.
If we take my first PowerPoint with the emoji.
You're doing great.
And if we take it to a conference, I'll put pictures in there. So next step, of course, is to continue to engage in everything, continue to interact with these tablet patients, not to support their use, but also to ask about their experience and try to get feedback about that. I know our nurse practitioner think they've been very helpful so far. And we do want to enable more patients with this kind of technology, either through the working with the county or through possibly our own funding. And I'm currently working with what data we do have. Thank you.
Thank you, Dan, for taking care of my people.
Yes, Del, thank you. Let's hear from Legal Hospice.
Hey, everybody. Can you see me?
Hello, Lisa.
Yeah, hi, Lisa. Hey.
How are you all? Okay, so our Legal Hospice of Texas Return to Care project involved us running projects through 2020 to see basically the demographics of the people we were serving during the pandemic. And after running reports, we did realize that we had a disparity in two different groups. So we are focusing on the Latinx community and young adults age 18 to 24. And I did put a picture here of our staff. We have myself, I'm the client services director, and then we have Jasmine on the left. She is our client services coordinator. Joel is our legal director. Pete Flores is our interim executive director, and Jennifer is our staff attorney. And then other stakeholders for improvement are our board members, our LHT Quality Management Committee, partnering agencies, both HIV and hospitals in the Dallas EMA, and our community, whether that's volunteers, events, or our client experiences. Next slide. So for project initiation, I have our chart here that we got our results from. So we were wanting to increase the Hispanic population that we're serving, or Latinx community, from 12% to 20%. That's a really high number, but we're optimistic, and we'll see halfway through this year and see how that goes. And then for the youth population, I say youth population, but I mean young adults age 18 to 24. We basically don't really see anybody from that age group. So we want it to increase from 1% to 7%. And I know that we have a lack in these two groups because we don't really have a presence there. So we do have like target zip codes, and they involve like the Southeast Dallas area, Oak Cliff, Pleasant Grove, South Dallas, and a little bit of like the Harry Hines area up in North Dallas. And the next slide. So for implementation, we did get our website translated to Spanish this past week. So trying to remove those language barriers, because if we want to increase how many Hispanics and Latinx community members that we're serving, we also want to have make sure that we have the resources to connect with them once they do come to us. So we do have a Spanish speaker on our staff. We are in the process of translating all of our documents too for the clients. And then another thing that we worked towards was transitioning to fully digital. Legal hospice before the pandemic was basically all paper. So now all of our appointments are over the phone. Everything is done digitally online. So we finally got our surveys transferred to digital with a QR code. And it's been a lot more effective. Now, we were seeing basically like a no response rate during the pandemic with our mailed surveys. And now we are seeing like a 6 to 10% throughout the last few months that we've sent them out, where our clients are responding to us and telling us about their experience. And we're also doing a like refer a friend thing with our QR code. So we're sending out a QR code when we close the case, and then we're also sending out more information for you to give to a friend to tell them about us. Okay, and then next slide.
Sorry, I was making a comment in the chat room. Here you go.
Thank you. So for next steps, we have building relationships. I did get to go visit AIN and AHF in December to like leave our brochures and just make that connection again with the case managers. But we have not had the chance to visit any of our other partnering agencies. So that is on our to-do list. You will be seeing me soon, and you probably see your name on my board. So I'll be visiting you. I'll be dropping off Legal Hospice's information and hopefully connecting and making a presence at any events that you guys are having. Please keep us in mind if you are also seeing a lack in the communities that we're seeing in. I would love to connect. And if you think that the people that you're serving could use us or need some legal assistance, please send them our way. Email me, call us. We are happy to serve you guys. And then I also included our AIDS walk because Legal Hospice will be participating in the South Dallas annual AIDS walk coming up in March. And that is all.
Awesome.
Thank you guys so much.
Yeah, thank you for sharing those concrete steps to be more accessible and have communication with people. And you totally teased a little action item, action planning with connecting with the other agencies. So that was great. Next up, we have dental, community dental.
Jonathan Bingham here, Grants Programs Director at Community Dental Care. And we are, like Legal Hospice, one of the smaller agencies that really focuses on one service category. And one thing that we've really been focusing on is transitioning to a preventive model. Most people understand dentistry as a model where you go to the dentist when you have pain or anything like that. And we really want to focus on the preventive measures because strong prevention can save the overall system a lot of money. And as I like to talk about that in the Ryan White sense, we can serve a lot more clients with the same amount of money if we focus on prevention and keeping those people in care. So that's how we put our project into the return to care. It's all about retention. And so next slide, please. We really focused on our preventive appointments and pulling data from our EHR. And we really wanted to identify which patients were in care and out of care. And this little snippet of data there shows we basically, a lot of people have the 6-month appointments or 3-month appointments, depending on their needs and gum health. And so we really have a 7-month, we work a month in there, a 7-month data packet where we are really seeing if patients are staying in care or not. And so we were able to identify quite a few patients who, by those rules, were out of care. And we also tried to do some stratification using our EHR data and found out that we did have some gaps. We had a lot of null values where maybe gender was missing, not necessarily gender, but we really didn't have a lot of individuals that we knew were transgender, that they didn't show up as that way. In our EHR, they had showed up as their gender from the common intake form that they may have filled out 10 years ago. So we're working on improving that data. Initial findings, we found that we had some people that were out of care, but were still coming. So they were focusing on those interventions, the treatments, rather than the prevention. And so we reached out to 150 of our patients, which were identified as out of care by phone. And we weren't able to reach all of them, but we did reach a really good portion of them. That was over half. And that constitutes that we reached out to about 10% of our total population that's funded by Ryan White. And really, they like to come up with different excuses, but most of the issues were simply that they forgot their appointments, or that they really wanted to focus on prevention, on the treatment appointments rather than prevention. And so next slide, please. Led us to a couple of projects that we wanted to put in place immediately that were more quality assurance, but immediately we started talking to our staff about improving our data accuracy so that we can work on this project moving forward. We're also working on the quality improvement side, patient education in our offices, so that we can really stress that preventive. Our patients a lot of them think that coming in for your prevention is wasting an appointment. They could be in for treatment on getting dentures or getting fillings done, but really there needs to be that focus on the prevention so that there's fewer fillings and less need for partials and dentures in the future. And then also we're really focusing on appointment reminders and trying to find new technologies and ways to do that rather than just calling our patients in the days before their appointments. Next slide, please. Our next steps, it's really looking at the data so that we can show improvement. And one of the things that we really want to do, working with Michael and his team, we've seen that our data can be very helpful, and we're going to look at stratifying it and look for disparities. And as we improve this data and get as I said earlier, we have a 7-month, right now we have about a 5-month data set. And if we can move into the middle of this year, we'll have a full year's worth of data, and we can actually start seeing improvements, because we need at least 7 months before we start having any changes to our data that are going to be noticeable. And then we're also going to be working, we have Paragon organization and affiliate organizations across the United States that are working on innovation and telehealth and prevention in particular. And we're really going to be focused with them on educational materials, finding new ways to stress the prevention with the clients. And then hopefully in the future, if we really get some good data, we can work on potentially either with Michael's group or just with our affiliates on writing some articles that really show how preventive care helps the HIV population and really shows us a cost savings to the system overall. And that's where we are.
If I can, just real fast, Jonathan, as a person living with HIV, I love the way that you are forcing the issue that, in the United States, we've had this problem or this deficit of thinking and imagination over the last forever, that somehow medical care is different from your mental health care and dental care. So apparently your teeth and your brain are not a part of your body. And I just think that it's so great to think about what clinical role dental services play and obviously quality of life, but there's significant mortality risk, and we don't want to think about that because it's 2022 and it's not 1983, but there's significant mortality risk if you don't actually take care of the preventistry. And I just, think that this is such a cool project. Thank you for sharing.
Thank you.
Awesome. Yes. Thank you, Jonathan. Let's hear from ASD.
Good morning. I'm Dwight Harry. I'm the program data analyst at ASD. We provide housing for the homeless that are HIV positive. Our QIP project involved one of our properties called Hillcrest House. The disparities of disability are extremely high at this property. So we wanted to look at increasing the percentage of people exiting to positive housing destinations by 10%. And we would measure this over 1 year based on our previous 2-year average of 73%. So we were targeting that, and the team that worked on that was our ASD quality management team of 19 individuals. It included both the executives and the frontline staff, along with some administrators such as myself. What we learned was that one of the key things was proper data going into our measuring of the outcome. So we improved how we put data into the MDHA HMIS system. And then we also improved the communications between the staff that was doing that, our case managers and so forth, when the client actually exited ASD. So based on that, we also looked at the underlying, we learned about underlying causes that were responsible for creating those negative exits and designations, which happen to be primarily drugs and mental health. So if we go to the next slide on project initiation, we went through a fishbone diagram session. It took us a couple of weeks to do that. And then based on that, we discovered how we wanted to approach that to show those improvements. And so we used that diagram and our performance metrics, and you'll see below some of the performance increases over the last 2 quarters. We'll continue to measure through June of this year, but already we're seeing an increase of 20% based on what we've learned. So what we did, if we look at the next slide of the implementation of changes, we improved our clients' job retention and thereby improving their income productivity to help secure that they could stay in a private apartment, or once they exited the ASD property. And we did that by securing an ASD vocational coordinator that was specifically focused on job income disparity within this Hillcrest client population. And so based on that coordinator doing that, we also provided assistance with drug and mental health problems. So we had to go out and hire some of those resources. So if you look at our next step slide, one of the things we did was hire that vocational coordinator, and we measured the rate of people that were being seen and measured by that coordinator. And in support of that coordinator, that case manager worked with also a crisis intervention manager for that particular population to help them retain that job, retain that income. And if they weren't able to have a job, we made certain that they obtained some disability income so that when they were ready to exit the program, they would exit to a positive destination as to going into those negative environments. And then lastly, we updated our policies and procedures in support of that. Thank you.
Awesome. Thank you. Love the social determinants showing up again. Let's hear from Legacy.
I'm Melissa Grove, Executive Director of Legacy Counseling Center. So our goal was when the pandemic hit in 2020, we had a decrease of clients as we converted to telehealth. Although our surveys were showing it was very popular, we had a decrease. And so our goal for 2021 was to reduce the no-shows. Our therapists are paid by the session. The clients don't show up or don't come to the session, they are not paid. So we were having a lot of retention problems with our therapists because after 20 years of no problem with retention, we had huge problems with that because of the no-show rate. So we were looking at reasons for the no-shows and what we could do. Our executive team was myself and our associate executive director, who's taking over for me when I retire in September, our front office staff, and of course our therapists. So our lessons learned, we wanted to maximize technology. Well, it's not showing up on the slide, but also to come in with some new interventions. Next slide, please.
Yeah, sorry about that, Melissa. If the toolbars are over your slide, just kind of scoot them out of the way.
Thank you. So as you can see pretty consistently, in 2019, that kind of represents the new clients, but as you see, they massively dropped off in 2020. And then through our interventions in 2021, we did have a huge improvement, although you wouldn't know it from looking at this. Basically, we looked at attendance at intake and the coordinating of the paperwork and the attendance at the sessions and client retentions. And the reasons we came up with through different data analysis, interviews, surveys, one-on-one talks, clients forget. The paperwork is a huge one, and the clients were very overwhelmed with it. We had just converted everyone to technology, and then of course they may be able to master like a Zoom-like session, but what they couldn't do is upload the required paperwork. And since there is more of a, we have that every 6 months, we have on intake, let's say January 1st is their intake. A month later, there's the work that we got to do it again. 6 months later, we have to do it again. Our clients remotely simply cannot keep up with all of these updates. And we really worked hard to get that done. But as you can see, our no-shows in 2021, you do see a decrease in 20. You kind of see that we have improved that, but I think the paperwork was really too big of a burden, but we did have some improvement. Next slide. So some of the change ideas that have been successful. Reminder days, the call before, to review information to make sure they know how to get there in the bus. Paperwork to be completed by first intake session, and efforts to utilize the case manager paperwork first. We are not a case management agency. Of course, now we have referral to healthcare, but there was still a lot to work on as far as defining referral to healthcare in 2020. And so we're just now getting that down. We did set up technology to text clients the day of the session. And we do have a new thing we've done is the quality management. We've always used college interns quite a bit, but we have a quality management intern who is usually a therapy, a counseling psychology student, master's student, pre-graduate, who works with me on the QM, because it is obviously very, very time consuming to call everybody. But one of the things we do is we do an inquiry call by a quality management intern to debrief on no-shows. So anyone who attends less than 4 sessions, we figure after 4 sessions, they're pretty in with their therapist, they're pretty set. But if anybody comes less than 4 sessions, and that includes the intake, we want to know, why did you drop off? Was it because the paperwork, you couldn't get all the paperwork together? Because you didn't like your therapist, because we dropped the ball, because you got your needs met, because it was too inconvenient on the timing. So because of that, we were able to really process those issues and figure out what else we could do to decrease no-shows. So we did decrease our no-shows in that way for sessions. And then the next slide, please. So our next steps, we're going to continue to implement phone calls, completing the paperwork, text reminders, and phone interviews. And we're going to, we focus more on measuring the intakes. It's a little trickier with the counseling sessions because you don't know if a client isn't coming because they got their needs met or because they no-showed. But we're going to try and track that down in 2022 of better ways to monitor that. And look at that. And another one is I see a lot of comments popping up. Yes, there are so many the half birthday requirement could ultimately mean a client has to bring the same thing in 3 times in a 7-month period. It's excessive. And I was talking to Michael about this. I think we constantly are wondering why are clients out of care, when we are the ones creating the barriers through our systemic systems of requiring certain things. Generally, our clients are not switching over to millionaire status in a 6-month period. And so I think we had done the 6-month thing to go along with the state, who had done it to go along with the ADAP. But I would like to urge anyone on this call who has any power of change. It's an incredible waste of time. It keeps positive people out of services. If anybody else wants to comment in the comments to back me up on this, but it does keep clients out of services. And at the end of the day, it gets very expensive because people are more prone who are not on the meds to infect other people.
Yeah.
And so trying to get an additional piece of paper every 6 months is really a silly thing. And we are the ones creating a worse problem.
So you've hit your limit, Melissa. But I think that you're raising a really important point, and I did emphasize that in the chat room. And I think if folks are able to comment on it in the chat room, or definitely keep processing this with our hearts and minds as we move forward into additional CQM performance measure work groups. Requirements are requirements, standards and expectations are standards and expectations, but we do have the power of creativity and innovation to be able to make this work. So that we don't string out our clients. And I think that is a really important take home. And you are a key mental health provider for our area. So you would know what are some of the things that are the hot button issues that, kind of like turn off some of our most vulnerable clients. So it's stuff to think about, and definitely, for those of you who are able to process this at various levels, process away.
Thank you.
Thank you, Melissa. Thanks, Michael. Let's hear from Parkland.
Look at that timing. Okay, I just put in the chat that speaking of silly paperwork, our QIP is about silly paperwork. Though we wanted to join in with the continued project, Parkland had to pivot. And so we did, in an effort to align and respect that really focused, intensive effort, we focused on removing ourselves as a system barrier. So we worked on system-wide change of a project that was brewing at the similar time that everyone was discussing this R2C. We focused on improving technology and access to clients through a platform that we do have access to, that's available on the client's phone or through an email, on any kind of device that they can have access to. And our team was a multitude, internal and external partners, from a clinician champion who led the way and allowed us to kind of get some leadership from larger Parkland to buy into the project. And then from Parkland's IT team, our financial counselor champions, our grants champion, Kelly, who's on the call, we needed to know and make sure any of the changes that we made would be able to be audited and meet all of the quote unquote silly paperwork requirements that exist currently. So next slide, and I'll take you into it. Don't panic. I'm not going to review all of this slide, but I'd love to. I will tell you that this is the work by Dr. Chow, our clinic champion, and he did a really robust analysis where we worked to understand retention barriers. We found specifically that clients who are solely funded, we have clients who are multiply funded across different kinds of funding, to keep being redundant, but that said, we do have clients that are solely funded by Ryan White, and we looked at any client within that didn't maintain continuous coverage, right? Because continuous coverage ended up popping out as a recurring barrier that from client survey, from looking at Jeremy's analysis, we saw that there was a predominant 70% likelihood that those with larger lapses were men, and we're in the Black racial ethnicity population. And so from other work, from our SPINS work, and just a continued root cause analysis that's kind of ongoing in our department of breaking down to see who is missing their best outcome due to potential barriers that we provide or accidentally implement, is our Black men under 35. And so we had done a robust survey with that group of perceived barriers, even after a 9-month intervention. And 60% of those respondents still indicated 9 months post-intervention that they saw, understanding of coverage, cost, and privacy was still a barrier, and transportation, right? So those pieces all just kind of added up to, of course, we need to make some systems changed. And with the eligibility, in Parkland, since we have, so all of our clients are multiply funded and we're a safety net hospital, we put the eligibility into our financial counselors' hands because they're able to quickly go into Medicator, establish and run those applications and maintain those. And it's really important, especially for some of our clients who don't have cross coverage, to be able to provide care for Ryan White in an outpatient setting, but they have to be partnered with Parkland's Parkland Pay to allow them to receive inpatient care if they need that care or specialty care. So launched our effort. So next slide. Okay, so I went ahead and just skipped to what our outcomes were. I could fill your ear on all of the steps that were necessary, and Kelly can attest. It took a lot of work and a lot of anchoring and buy-in to get all of the steps in place that met our clients' needs. And though it was a system-wide approach, right, this MyChart utilization that aimed to send a happy half birthday message, we pushed that message and built a questionnaire through MyChart that would then pop up into the client's inbox. And let me tell you, we have a lot of night owls. They would then be able to open it and easily at their leisure, they'd have a month to be able to either attest, that there were no changes. If there were changes, they could then, attach and supply that documentation to our financial counselor. Our case manager would have access to those documents. And it just was trying to kind of align and reduce our in-person visits and also just that gap. And they would have kind of a reminder at the first of their half birth month, hey, this is the time when we kind of just move that dial forward and keep you covered to where you can keep getting the same access to medications and to care and to mental health services and to outpatient and to ASD and to, legacy, right? All of our contingent partners. And so we were trying to reduce our inpatient visit, and we really feel like we achieved that so far. So far, so good. We wish it was impacting our retention immediately. It has not. With COVID and just other factors, we still have work to do with retaining our clients in care. But for us, mastering and kind of learning about how we can leverage a big platform to reach patients where they are, when they want. If you're a night owl, fine, because we certainly don't have our outpatient clinic set up at midnight, but they can get some of their paperwork completed, feel comforted and assured that then when they go in for that visit, that they wouldn't have a bill or be greeted with concern or not being able to be seen until that was, brought back in line. So MyChart is also where we have our telehealth visits. And so this just begins an effort. You can go to the next slide. This just kind of tiptoes into the effort of really anchoring how we can let our patients access care at their availability. It's the flexibility that Parkland can provide, because we all know that's a big ask from a big organization to be nimble. I don't think we're known across the Dallas County for being nimble, but I would give us some huge credit for where we are able to make some shifts. And our biggest consideration, if I have remaining time, is prioritizing training and frequent check-ins. So we, with our clients, with our staff, it was really, we anchored from the beginning to train, and check in. Staff changes, clients coming into Ryan White change, right? So we do have our anchors of clients who've been living with HIV for a while. We do have many clients who come into the system or re-enter the system that still don't understand Ryan White and how that differentiates from other payers. And so just kind of consistently training our staff in how to do simple things like, did you forget your login? Did you forget your password? Here are ways that you can do that, because that causes full stop for me. Once I get that first message, I'm mentally exhausted, and I can only apply that to our clients and our CAB and the case managers that were bringing those information pieces to us. And so we learn every single month of the push from August till now. We've done small iterations in that PDSA cycle, right? We revisited with, oh, I thought we were doing this. Let's really do this. And we thought something would be a concern. It was not. And across the age gaps, our priority population were men under 35. Across the board, we were able to increase to 32%. So we reduced 219 clients, 30% of the push responded, but within the under 35, we bumped up to 37%, and
Great.
under 25, almost 57%. So we're getting there. And the next step slides is just the work that we continue to have ahead of us.
Great. Thanks so much, Piper. You
Absolutely.
fit a lot into that presentation. And again, I just want to emphasize something that I had said previously and put in the chat room. I love how our projects are resonating with each other, and that the learning that we're having in one center is being supported by the learning and activities in another center, and that there is a lot of synergy here. And we should take those synergies with us into some of our external quality committee meetings at the AA level, into our performance measurement work groups, to really think about how our healthcare neighborhood, currently works and how it can better work. Because so many of us do share clients as well. This is such a great presentation. And I think we have one more. Is that right, Jamie?
Well, we'll hear from Norma and Cali Clinic and then HSNT.
Hi.
Hi, take it away, Norma.
My name is Norma Peel Brown. I'm the compliance officer as well as the CQM coordinator. I work at an organization called Cali Clinic. We've been in business since 1991 and serve the far north Texas area, 3 counties in particular, Grayson, Cook, and Fannin. We're mostly rural. We're the only Ryan White clinic in that area. We're a one-stop shop. We serve over 15, or we have over 15 Ryan White funded services. Similar to some of the other organizations, we had an existing QI project that we kind of massaged to fit into what Dallas County was doing. So we knew we were going to do viral load suppression. We added retention and care. We knew we wanted to focus on social determinants of health. Our choices were housing, mental health, homeless, substance abuse, and age. We chose age because we knew that our population, our older population, was very large, which kind of goes along with all the epi data that people are getting older, living longer. We used a tool that CQII kind of formulated called the disparities calculator, which allowed us to narrow the focus of the age group. And I've kind of showed it to you in the first slide. We found that there were 2 populations that we could focus on. Youth are 40 to 64. Normally it's done with the age group with the lowest viral load suppression. In this case, we chose absolute impact, which of those 2 groups, where would we make the most impact, or basically the bang for the buck? So we chose the 40 to 64 year. Next slide. We got to get the QI team, basically is our CQM committee, which is composed of 3 consumers. We utilized a brainstorming session to get at root causes. 1, 2, or 3 of the things we wanted to focus on was our mental health referrals taking really long, and we were losing clients. Additional was our case managers' burnout and potentially getting them more training. We developed our aim statement, and we were going to monitor, as I said, both viral load suppression and retention and care. Next slide. Change ideas. We selected an intervention called the Undetectables program, which is basically a stepped approach to ART adherence for people who may have mental health issues, substance abuse, experiencing homelessness, or age-related challenges. It's basically, it would be an individual level ART adherence support, monthly client and case management support sessions with oversight by our ID provider. One of the things was this was going to be a long range QI project, which is why we haven't perhaps gotten as far along as some of the other organizations, but we're going to get there. We were going to develop new MOUs with mental health providers. The undetectable programs utilizes tangible reinforcements once you get to a certain viral load, and then the selection of the clients to participate, and some motivational interviewing training for our case managers. So the next slide. Where are we? We've let the CQM committee know all along where we're at. We've developed a list of client recruits. We have developed some new MOUs and are still looking for some other MOUs. We've found training, a motivational interview training. We haven't started it yet. What's left? We need to develop our curriculum for our adherence program. Basically set a tentative start date of February 14th. We have been checking our baselines all along, but once we start the program, again, we'll continue with that. We'll utilize the regular case manager meeting to do debriefs, and then potentially by the tangible reinforcements, use them as needed. One of the challenges is this is a long-term queue. It's not a fast turnaround. So it's long-term. It requires development and it has time challenges. Next time around, I might think smaller. To as broad as this is, but it's good. It's good. We're happy with it.
It's great, you know, and I'm glad that you're using something like undetectables, which has shown so much success across marketplaces and across populations, you know, in this country. And, you know, we're all rooting for you and seeing how it pans out. You know, I think when it comes to people who are, you know, super capable and very passionate, keeping it small and manageable is one of the biggest challenges that we have. So, you know, I think that, you know, that feeling will resonate with other people on today's call too.
One of the things we've, and this is all I'll add to, is getting consumer input on this. What we found was the consumers really do like to be incentivized. So I'm thinking that's why we chose the undetectables. It allowed, you know, our consumers advised us that potentially doing gift cards would be a good idea, and they liked it.
Thanks.
Thanks, Norma. We'll move it over to HSNT as our last poster prezi.
Okay. Hi, everybody. I'm Christina. I'm the Program Case Management Supervisor at Health Services in North Texas. Our project was a Get Connected, Returning to Care project that we did with our clients who are either lost to follow-up or were behind in their care. Can we go to the next slide, please? Our hope was to decrease the number of clients who were out of care or behind in their care by 5% by December 31st of 2021. So that just ended. My team was Merlene Wilson. She's our Senior Manager of Programs. I'm, of course, the Program Case Management Supervisor. Karishma Patel is our Clinical Informatics Consultant. So she helped us develop a lot of processes. And then Kim Allenbar, who is our Quality Coordinator, who does a lot of the reporting pulling. So they were all amazing to work with. One of the things that we noticed with our clients is that we started this prior to this project, but that they had a hard time getting through to the case management team. And often what would happen is that they would leave a voicemail and in a case management queue. And then most of those calls that we determined were not actually for our department. They were for another department. So then the people who are our clients were not getting connected to their services as quickly as they would. So we decided to develop a live call queue to reduce the work for the case managers, because it's an hour every time you're having to go through that thing to upload it to other departments. The answer rate for the queue has increased, and the clients' complaints have decreased since we've done that. And we've been able to correctly route people who just press a number because case management answers. We also went about cleaning up the provider and the medical case manager panels to allow accurate identifying clients who are actually behind in care or who had fallen out of care. So we had actually gone back 3 years to see who hadn't been here. And then anybody who was in the last year and a half, we were able to reach out and talk to them. And by doing that, we were able to close the clients who were not in care with us, in care somewhere else, or who just never responded. So to keep that up, we do a monthly panel review every month to make sure that people are still in care. The next slide. We did a root cause analysis with the fishbone model that we learned from Jamie and Michael, so yay. And our discoveries were about the medical case management phone queue, and that we had a lot of out-of-date clients who weren't actually accessing services, but because they were out of care, their viral load suppression was affecting our overall goal in ARIES, which gives you an inaccurate number to do that. And then them not having the twice a year medical care also was because it was off. We also were able to reconnect with a significant amount of the people who are out of care just behind and encourage them to come. But it is, we still have to encourage them and call them to do it. A lot of them have some issues with their memory or being able to be consistent. And then we have made and are still making attempts to streamline the paperwork and the case manager duties so that there is a workflow that works, because you can have it on paper and it looks great, but if it's not working in real time and keeping evaluating that, it's not going to work. Can I have the next slide? Thanks. So we revised the phone system. So all of our case managers, to make it less daunting, they work a 4-hour live call shift. So we have 8 to noon, 1 to 5. And our answer rate has increased to 80.5%, which was a significant increase when we just had the voicemail that we were checking. Our clients have stated increased satisfaction, and most of them have their access to their medication in a timely manner, instead of us, having that voicemail check and then trying to get to them in the next, 48 hours. We can do it in real time. We do a monthly provider and medical case manager referral for healthcare meeting, and we go over clients who are maybe high risk or people who are at risk for falling out of care, and people who might just be referral for healthcare but aren't enrolled in medical case management. That's the opportunity where the doctor sees them and says, hey, I really think that this person would benefit from medical case management, so we can get those people enrolled. Or maybe they're not in Ryan White because they have insurance, but they have all these other needs that they need. And of course, we closed out the clients who are no longer in care, but we ensured that all those people knew how to come back in. And then, of course, we went ahead and contacted those people who fell out of care. And we're working on a process to be more accommodating for people that have attendance issues. We have a couple of providers who have authorized same-day appointments, and we're doing the same thing in case management. If they're out of care and they don't have eligibility, but they're getting the same-day appointment, we'll update that eligibility on the same day. We also have made it easier for clients by implementing DocuSign. And so we're able to, email those out and they can sign it in real time. Sometimes they don't check their spam if that's where it ends up, but we're able to follow up because we know what they haven't received. And we do a lot of telephonic updates with that. So at the beginning of our return to care, we had a 31.9% 91% out of care rate. Now ending, we're at 14.70. So that is a 17% improvement, which is super cool. The next slide. So like Norma's, ours is going to be ongoing, and I'm sure many of yours are the same way. We have currently 2 vacancies that are open. We have a referral for healthcare opening, and we have a medical case management position in Denton. So we're working to get those filled, so there's more access and we can distribute the work appropriately. We're going to continue the monthly review of the client panels. We're also going to implement a daily team huddle where each of the case managers review 3 clients and make sure all the paperwork and everything's in there, so that if they're missing something or maybe something fell through the cracks, that we can go ahead and get those updated in real time. So that's it.
You did a great job, and we only have a couple of moments left. We did such a great job sticking to the time, and I feel as though the lightning round kind of feel of our presentation, was successful. We were able to really show how we work off of each other and bounce off each other. And in our last couple of minutes, I would just like to invite any of our special guests, whether you work with Achieving Together or EHE, or at the federal level or local or state level, to just share some of your thoughts on the common threads and possible food for thought or ahas that you've had listening to all of our subrecipients present. Oh no, Sonia,
Sure.
Oscar, yeah, go ahead, share.
I would love to say something. I mean, I thought this was fantastic. Everyone's ideas were just so thoughtful. You can tell all the hard work that went into it. For me, I really enjoy just hearing all the different priority populations that are being focused on. It's very diverse, which is always encouraging for us to see. I hear your frustration about the paperwork burden, which is why we came out recently with the PCN 2102. And I've been working with Sonia and her team around what their plans are for that, as well as with the state on the ADAP side. So hopefully there'll be some changes soon that you all will be seeing, because we do want to make things easier for our clients to be able to access care. So thank you all. Keep up the great work. You gave me some great ideas I plan on sharing with some of my other jurisdictions. So thanks for the invite this morning. It was wonderful to see everyone and meet everyone and just learn more about the work that you're doing on the ground.
Well, thanks so much, Kristen. Definitely feel free to share that link with any colleagues. I think when we think about the 2022 TA calendar, maybe a piece on the new PCN and how we're implementing that at the state and local level. Once we're ready, we don't want to push, partners that are still figuring it out, but once we're ready, it might be a good thing to have that as part of our series. So I love that. Anyone else want to share? Miranda has a chat in the note here. She took a ton of notes. I'm going to try looking through the chat. I might disseminate the chat as well with the video, because it was an incredibly rich conversation in there.
I just want to say thank you all. What a great just series of wonderful presentations and great work. I'm so proud to work with you all. Thank you for all the great work you're doing in your communities. Just really impressed. The use of the tools that Michael has shared with you, and the Dallas AA supporting you all and getting you all together and launching this, a regional project. I remember when we first started meeting, and now to see this come full circle and all the great progress. It's just wonderful. It's so rewarding to see. I cannot tell you. I hope this is recorded so I can go show Janina and Jesse and all the leaders at the state. So thanks again.
Thank you, Yulin.
Yes, definitely echo the same sentiments as Kristen and Julie. We appreciate your work and the effort and kind of seeing it manifest and allowing you to present about it and then support one another is even better. So it was wonderful today. So thank you.
Yeah, and I would like to say on behalf of our security team, Angie, Regina, and myself, we appreciate that you're building up. With the great guidance of Michael and Jamie. We are halfway of those posters. At the end of 6 months, we have data. This will be rich, and you are the stars. Again, thanks for the support. at all levels. This is growing beautiful, like we dreamed in 2019. Thank you so very much. Appreciate that. And let's keep doing it. Let's keep communicating like as we speak. Thanks.
Yeah, I think we'll pause the recording. Look for those materials to come out. I want to echo what everyone else has said. This was a little wonky or unusual when we first started, but today we see why we do the work we do and all of the value add and the way we can complement one another and leverage each other's strengths. So fantastic job. This is like the highlight of my whole week. So thank you for starting me off right, and we'll see everyone soon.
Thank you.